that determines the fertility potential of an individual, or as a couple, as the case may be. First is the fact that for a woman, in particular in the couple, we need to know that the fertility of a woman is, of course, dependent on her eggs, in terms of the quality of the eggs, as well as the quantity. Now, for a woman, we need to know that by nature of the creation of a woman does not make new eggs in her lifetime. In other words, whatever eggs a woman has at any stage in her life, she was born with, or in other words, a woman is usually born with the number of eggs she will ever have. So at birth, a particular woman will have the highest possible number what she was of eggs, and of course the quality also. As she grows older, the eggs reduce in quantity and quality. Now, so in other words, age is an important factor in considering the fertility potential of a woman. Now, how does age affect us as women? Basically, two ways. As you go through your normal menstrual cycles, you lose some of those eggs every month as you menstruate. Now, so even if you're born with whatever millions, ultimately the number depreciates with age. Now, the second way age will affect us is the fact that as we age, our cells also age along with us. So, and cellular aging in particular, as it affects the quality of eggs, it has to do with whether or not the DNA of the eggs are intact or damaged. So with age, DNA damages occurs, and that may affect the quality of the eggs. So two things: age depreciates the number of eggs, and then the quality. Now, this is very important to know before we talk about the core issues of when we want to start infertility journey. And for the man, yes, we know that, yes, indeed, a man has a potential to produce new sperm cells or spermatozoa every time, irrespective of his age. But yet, we do know also that as we get older, our generally cellular qualities depreciate. So that may also affect sperm in the sense that with aging, we realize that sperm quality may also depreciate in terms of DNA quality. So having this in mind, we need to know that, of course, generally what this means is that for us to start fertility, the earlier in age, the earlier the better, usually, once you consider when. That's the general principle we need to keep in mind. The fact that at whatever age, at whatever point in time in life, once you conceive the idea of fertility, the earlier you start that, the better. So, what's the ultimate or optimum age for men and women? Generally, for the woman, it is considered that between the age of 18 and 25, that's the optimal reproductive age for the woman. After that, particularly the reproductive potential of the woman may depreciate, particularly after the age of 35. After the age of 35, there's what we call follicular atresia that gets faster. What it means is that her pool of eggs actually gets diminished very fast after the age of 35. For the man, that does not happen. However, we have to keep in mind that DNA fragmentation, DNA disruptions may affect the man as we age. So, having discussed this, we now go into when is the most appropriate time to start your fertility journey. And I'm going to talk about this in two ways. I will talk about before marriage and then after marriage. Now, before marriage, it's important to know that whatever we do now, irrespective of from childhood to adulthood, can, especially certain behaviors, certain lifestyles, can affect the fertility potential of any one of us. It could be a man, it could be a woman. So in that regard, we need to know that when we think infertility or fertility, we have to think about certain factors or certain lifestyles that we may need to adopt to preserve our fertility potential. Now, this may actually go back to way back when we were in our mother's wombs, because the thing is, there are certain things that would happen to a pregnant woman in terms of exposure to certain infections, exposure to certain medications, or even lifestyle of the woman while pregnant, and exposure to some environmental toxins that could actually affect the baby while the baby is in the womb. And in this case, it would affect the fertility or development or formation and development of fertility organs, to the extent that the child may be born with certain defects or abnormalities that may affect his or her fertility potential in the future. For instance, for the male child, there are certain situations that could occur while the male child is in the mother's womb that can affect the descent of the testicles, to the extent that the baby may be born with one or both testicles that have not descended into the scrotal sac, and that can affect the fertility potential of the baby in the future. Now, for the female, of course, there's so many things. There are certain substances the woman may be exposed to during pregnancy that will affect the unborn child's reproductive system in terms of their development, their formation, development, to the extent that the child may eventually be born with certain abnormalities related to the reproductive system that will affect her in the future. In fact, to a very large extent, even the number of eggs the baby is eventually born with may be affected by whatever it is that happened to the woman in pregnancy. So, having said this, when we're born, of course, during childhood, there are certain things that could also happen. For instance, sometimes uh, children may be exposed, in this case, male children, for instance, who have had maybe birth conditions like what we call congenital hydrocele. Congenital hydrocele is a collection of water or a situation where the young baby's scrotal sac is directly connected to his abdominal cavity, such that water from the abdominal cavity goes into the scrotal sac. Now, this usually will require some kind of surgical intervention. Now, where the surgeon who does the surgery matters, because sometimes we've seen cases where such children ended up in the wrong hands, and the surgeries eventually ended up with the baby's what we call spermatic cord being ligated, and such that at the end of the day, if it is bilateral, if it is both sides, the baby boy may end up with fertility issues in the future. So it is important to know that even in childhood, there are certain things that we do sometimes that can affect. For instance, one other situation we can see is if a child is playing football, for instance, and the football hits his scrotum and all of that, sometimes if there's a damage to the testicles at any stage in his life, that can affect his fertility potentials. In these times, there is this whole topic of what or chemicals in the environment that can also have potentials to diminish our fertility potentials. Things that we generally call endocrine disruption chemicals. They're all over the place. It is important that we keep our children as much as possible away from exposures to these substances in order to preserve their fertility potentials. So for the girl child, of course, as I said before, there are certain abnormalities the girl child may be born with that may interfere with her fertility potentials in the future. So, so therefore, while growing up, of course, we need to be careful as well. In teenage age, we need to watch ourselves and prevent ourselves or protect ourselves as much as possible from contracting certain conditions, particularly STIs or sexually transmitted infections in teenage age or in early adulthood, whereby exposure to some of these things to the organisms can actually entirely diminish our fertility potential to the extent that for a woman, for instance, who is exposed to such things earlier in life, that may affect the status or the condition of her tubes. And in places where, or in conditions or situations where the tubes get blocked, of course, that would affect her eventually. So even in teenage age and early adulthood, we have to be extremely protective or careful what we do, because if we keep fertility profile in mind, we have to watch what we do to protect that. Now, as long as things that we are born with are concerned, we probably can't do anything about that. But of course, things that we may acquire in life while we grow up, of course, there are things we can do something about. Now, these days, we see quite a number of young ladies coming out, coming down with hormonal issues, particularly issues around things like polycystic ovarian syndrome, which we do know that it can actually affect fertility potentials for young ladies. Now, the advice is that once we see ourselves having to deal with that condition, it's important that we think about fertility early, because the earlier we address uh, the issue of childbirth, if you come down at any stage in your life with polycystic things like polycystic ovarian syndrome, for instance, the better your prospect of having a child. The longer you wait with that kind of condition, the worse the prognosis is as far as infertility is concerned. Now, generally speaking, therefore, we advise that um, at any stage in our life before marriage where we suspect that we have issues or things that may have potential to affect our fertility, it will be appropriate at such time. Don't wait until you get married. If you suspect or think that, well, you have a condition, both males and females, you have conditions that may potentially or has the potential to affect your fertility, it's important that you seek help early enough so that some things that can be corrected could be corrected earlier. Those that may not be corrected, of course, you will have the information earlier and you'll be probably advised by your caregivers as what you should do next. Now, when we get married, when we get married, when is the best time to start? When is the best time to think of visiting your fertility caregivers as far as infertility is concerned? Now, in this, for this situation, when we get married, there are criteria, there are guides to as per when we should start the journey. Now, the guides, first, we look at the age of the woman in particular, in this case, in the union. The age of the woman is very critical when it comes to egg quality and quantity, as I said before. So, generally speaking, we say that if a woman gets married before the age of 35, if she stays with her husband, okay, and stays with her husband, then for up to 1 year of regular unprotected intercourse and there is no pregnancy whatsoever, then after 1 year of marriage and regular intercourse, they are supposed to seek help. That is for a woman that is below the age of 35. I have mentioned in the beginning why the age of 35 is important. As I said before, it's important because after the age of 35 in a woman, follicular atresia or egg depreciation becomes very fast. In other words, the fertility window begins to close much more rapidly than before that age. So for that, we want to advise couples below that age to wait till 1 year. Now, in this waiting period, it's important to fulfill the criteria of regular unprotected intercourse for at least 1 year. Now, when we say regular, it is advised that we have at least twice two intercourse in a week. 2 to 3 really is considered enough for up to 1 year. Now, where you know as a couple that for whatever reasons, for job reasons, for logistics, distance between you and your husband, uh, does not allow you to fulfill this criteria, then of course you are not a candidate to keep waiting for 1 year if you know that it's impossible for you to fulfill this criteria. So it might be appropriate for you to give yourself a little time, and perhaps within reasonable number of weeks or months, you should seek help when necessary, even if you are below the age of 35. Now, for couples where the woman is above the age of 35, it's important to know that for them, the advice is not to wait until 1 year. Generally, 6 months it's enough to wait. Now, in this 6 months, too, it is believed that you would have had regular unprotected intercourse 2 to 3 times in a week, and after which, if you do this for 6 months and there's no pregnancy, then it is time to seek help. Again, as I said, as a couple, you have to be honest to yourself to make sure that you know that you have fulfilled this criteria. Now, these two criteria regarding the age, uh, it's what is generally accepted as 3 months, 1 year before the age of 34 years. Then, after the age of 35, you wait for 6 months and see. Now, this is not sacrosanct. It is important to also say that if before marriage we know that we have issues, existing issues, for instance, some of us before the marriage, even before we probably get to know about certain things that may impair or interfere with our fertility. For instance, if you have polycystic ovary syndrome, you are aware of, or you have other medical conditions, or sometimes even the presence of fibroids, especially where the fibroids are significant in sizes, and wait for wait for for you who already know you have a pre-existing issues. I think it is not advisable that you wait that long. I think it would be uh, advisable that you immediately seek help or advice, at least without necessarily subjecting yourself to full detailed fertility workup. But I know that if you avail yourself with the appropriate specialist, you will be advised accordingly. Um, Generally, those are the things. So, in summary, what we need to consider first is the fact that certain things are very important. Age is an important factor for both of us, women or men, but it's more important in the case of a woman to consider. In these times, we have, of course, one of the possible reasons why we have increasing rates of infertility is perhaps the fact that the age at marriage and the age at um, first conception is probably getting more delayed. Unlike in the past, generally in our communities, especially in African communities, you hardly would find a lady above the age of 20 that is not married. Okay, but here, because of education, career pursuits, and all of those things, lifestyle has changed, and so we have women delaying age at marriage, and of course, age at first attempt to at conception. So these things ultimately affect the fertility potential. But then, uh, generally speaking, the earlier we start our fertility journey, the better the prospect of success. Um, in this, yes, there are few, we're seeing some, perhaps people have some questions, and I think there are some questions we might want to address. Okay, I see a few questions here from our viewers and listeners. I think I will try to address them as quickly as possible. The first question here says, I notice more flow of period when I use toilet rather than on the pad. Well, basically, of course, this is not directly related to what we're discussing, but then in the spirit of the month, we will also address that. When you notice, the reason you probably see more blood when you use the toilet is because you're straining. In addition to your own straining or pressure, called abdominal pressure, the other thing that pushes out the flow is actually what they call the womb contracting or uterus contracting itself. So in addition to uterine contraction, you're also straining either to wee or to do number two. And that's possibly the reason why you observe more flow in your pad when you use the toilet. Now the second question is, can diffuse adenomyosis affect IVF outcomes? And how can I shrink my uterus to improve IVF outcomes? Yes, the answer is yes. In fact, adenomyosis is one of those scary things you want to deal with as a doctor when you consider fertility as well. Even spontaneous pregnancies and IVF situations may be marred by diffuse adenomyosis. But then, of course, the answer to the second part of the question is yes, adenomyosis can be strengthened with certain medications before an IVF cycle, but the popular approach is to give certain injections, which may be given monthly or 3 monthly until the adenomyosis have shrunk well enough to to uh, attempt an IVF cycle. Now, the third question I had here: how can I freeze my eggs? Are there procedures, and what are the do's and don'ts to freezing my eggs? Well, the first thing is yes, there are procedures to freeze your eggs, but I think the first thing is, and these procedures, facilities, I can tell you, are available in most fertility centers. It's certainly available in our center. The first thing is that you need to prepare yourself early enough. Don't wait until, for a woman, I guess the question is a woman, don't wait until it's too late to attempt to freeze your eggs. If you wait until above 35, getting to 40, then the prospect of having very good eggs is getting poorer the older you get. So it's important that you make up your mind early enough and then approach the fertility center with the appropriate expertise and facilities, and they'll be able to guide you through the procedure. Do's and don'ts is, of course, the do's is do it early enough. The don'ts is that don't wait until it's too late. Because at the end of when it is too late, of course, the egg quality and quantity may not be good enough for freezing at all. Now, the fourth question I see here: how can we manage adhesions and still have a successful IVF procedure? Well, in this, I believe the adhesions you mean, the question means is adhesions inside the womb. Because if we are talking about adhesions or IVF procedures, we're not bothered about whether or not the tubes are open. In this case, I believe the adhesions we're talking about are adhesions in the womb. Now, there are two ways the adhesions can be addressed. The first, which is the best way to address such adhesions, is to do a procedure, minor procedure, using a camera called hysteroscopy. Now, a camera is inserted in the womb by the expert who knows how to do that, and then through the camera, he or she sees the adhesions and breaks them. Following that procedure, usually a device is inserted into the womb for 10 to 12 days or 14 days, and thereafter certain medications may be given to ensure that the adhesions do not come back. And usually after that, if you have the facilities, if there's a second look, what we call second look hysteroscopy, you might just discover that the adhesions are cleared. Now, depending on how bad the adhesions are from the beginning, if they are mild adhesions, the first attempt may clear them out. But if they are significant adhesions, you may have to do again to ensure that at least the adhesions are cleared completely before an IVF procedure is taken. Now, the next is IVF and fibroid. When do I remove it before IVF in terms of its size? Well, for IVF and fibroids, there are two things we look at. First is, of course, the size of the fibroids. The second is the position of the fibroids. Now, but more importantly is the position of the fibroids in terms of whether or not the fibroids are very close to the cavity of the womb, to the extent that they may interfere with implantation processes. Where the fibroids are not very close or close to the cavity of the womb, they may not interfere, except if they are so huge to the extent that they will fear that they may interfere with blood flow to the interior, to the cavity of the womb. So it is important to determine the position, the size, and their relevance to IVF success or failure. So, okay, so for this, usually once you have gone to the appropriate place and your fibroids have been assessed, the specialist in question should be able to advise you on whether or not the fibroids need to be addressed. But generally, for couples or for a woman going for IVF, fibroids are advised to be removed. Now, how long we wait? The advice is usually 3 months minimum after the myomectomy, after the removal of the fibroid before an IVF trial. The reason for that is we want the wound created in the womb to consolidate and get firm enough so that during the pregnancy, as the womb expands, we don't have accidental breakage of those scars to lead to a condition we call uterine rupture. So it is important that we know that we wait for at least 3 months following myomectomy before the IVF procedure. Sorry we had a break, but the next question I have here is IVF. What is the difference in measuring fibroid centimeters and millimeters? Well, there's actually no difference. It's a matter of convenience to whoever is doing your scan. Whether you measure in centimeters or millimeters, it does not necessarily change the size of the fibroid. So it is whoever is scanning that finds it convenient. If there are tiny fibroids, perhaps measurements in millimeters will be appropriate so that at least we can appreciate how small they are. If they are huge fibroids, I mean, measuring in millimeters may be very large. So it's a matter of convenience for the sonographer or radiologist or the gynecologist who is scanning you. So it doesn't really matter whether fibroids are measured. Now, I see a question about percentage of men who have varicocele and whether or not they can impregnate or not. Well, I am not a urologist, but I may not be able to, I don't have that figure offhand, but I see these days we have a significant number of men coming with varicoses. And as I said, I'm not a urologist, I wouldn't know why that is happening. But interactions with our urologist colleagues tells us that yes, we're seeing a lot of men these days coming with this. There are certain conditions that may make it worse, sedentary lifestyle, anything that tends to increase pressure in your domain tends to also increase the potential for that. But as I said, I don't have the figure of the percentage of men. Then there's, I believe, HSG's report where someone's report says that there was opacified uterine cavity and biconal uterus, but tubes are okay. Now, what this means basically is that the womb of this particular lady in question has two divisions. Okay, we call it biconate uterus. Biconate uterus, where we have one side is like a room that is divided into two by a small wall that indents into the room. So this in itself may not have may have a little problem with the fertility potential in the case that if the biconate uterus is significant, that may create recurrent miscarriages. It's one of those distant causes or congenital causes of recurrent miscarriages. But it's important that for any woman who has done such a HSG with that finding, it's important that you avail yourself with a specialist who can do hysteroscopy to be able to see the extent of the baconate situation, as it were, in the uterus, then to advise you appropriately on what you need to do. The other, I've seen my periods ceased for more than 8 years, 35 years. What can I use to bring it back? Well, your period season for more than 8 years and you're 35 years, generally at this age of yours, we don't expect that you go into menopause. Because once, by definition, once the period ceases for more than 1 year, in fact 6 months, we consider that, I mean, the uterus, for some reasons, the ovaries are not working. But then there are so many factors that may have caused this. One of which may be that perhaps the womb itself, sometimes following certain procedures like maybe evacuations in the past, we have sealed the womb completely to the extent that at this point the menses will not be coming anymore. But of course, again, there are other conditions that could affect the ovaries to the extent that the ovaries may fail prematurely. Now, if your period is not coming or it hasn't come for more than 8 years, that suggests that at about 20 something years, about 27 years, that was when something happened and the period ceased to flow thereafter. I will suggest that rather than doing any self-evaluation and the medication, it is important that you see an appropriate specialist, in this case, a gynecologist, who will evaluate you and then provide appropriate solutions for you. The other question I have here is what is the possible way of treating urine? I guess it is uterine fibroid apart from surgery. Well, generally there are many ways. There are ways we can manage fibroids, but we categorize them into two, what we call medical and surgical management. But as far as treating fibroids is concerned, as far as orthodox medical practice is concerned, myomectomy or removing the fibroids surgically is the best way to deal with fibroids. However, there are situations where a woman may not be fit for surgery or she's not ready for surgery. And if she presents with issues related or symptoms related to the fibroids, we can manage the fibroids with medications. There are medications that can diminish the specific symptoms that the patient may be presenting with. For instance, if bleeding is the problem, where there are issues, there are ways we can deal with the bleeding to the extent that it becomes acceptable. But if somehow the fibroids create pressure symptoms, sometimes we can give injections or medications to shrink the fibroids pending when the patient is ready for surgery. But as I said before, the ultimate way to treat fibroids is to remove them surgically. How does one treat hydros before? Okay, I guess I want to believe this is Hydrosalpinx before IVF because it seems to be a problem. Yes, indeed, it is a problem, especially where it is bilateral. Hydrosalpinx means fluid collection in the tubes, and this usually happens when the tubes are blocked, especially towards the end of the tubes, and fluid that normally or secretions that normally accumulate from the tube by the tubular cells that tend to gather within the tube and can interfere with fertility or for conception or with conception. How that happens is that the fluid that is collected in those tubes, what is called hydrosalpinx, somehow have a way of tracking down back into the uterine cavity, and that can usually that fluid is toxic to embryos, and that may interfere with the life of the embryo. So in IVF, if you do your embryo transfer and you have hydrosalpinx, sometimes the fluid in those tubes can flow back into the uterus and affect the capacity, the life of the embryos to the extent that you may not, implantation failure may occur. So how to treat hydrosalpinx? There are surgical ways. Generally, if the hydrosalpinx is minimal, there may be an attempt to open the tubes at the fimbrial ends. There are two ways it can be done. Where the facilities are available, the best approach is doing what we call laparoscopy. Laparoscopy is where a little camera, is put through the belly button of the woman, and small instruments, tiny instruments, are used to locate the tubes, and then a little holes are made at the end of the tubes to allow the fluid. But the drawback with this is that there's a possibility that the hydrosalpinx will collect back. You know, this can also be attempted in open surgery, but open surgery may be riddled with, in the recovery phase, may be riddled with what we call adhesion formations, and that may uh, lead to recurrence of the hydrosalpinx. Now, where we have hydrosalpinx, the best thing usually, there are two things that can be done, especially where the decision for IVF has been made. And two things is either the tubes are ligated or tied up such that the fluid does not have room to go back into the uterine cavity, or the tubes are completely resected away. Because once we have significant hydrosalpinx, we know that pregnancy is not possible anyway, so the tubes are as good as useless at that point. So they can as well be cut off so that the connection between the tubes and the uterine cavity is off. That way, they may not interfere with your chances of pregnancy in IVF. What protocol do you use for IVF for someone with adenomyosis? For us, here in the center, what we do is that we first assess the degree of adenomyosis, and following the assessment of it, if it is significant and diffuse, including hysteroscopy, what we do is we advise, of course, the couple accordingly, and then usually we have medications or injections we call the GnRH analogs that we can give for 3 to 6 months to shrink the adenomyosis, and then evaluate the woman later to see whether or not the adenomyosis has significantly shrunken to the point of doing IVF. So, but as I said, whatever it is we do, how long we do that depends on how bad the degree of adenomyosis. How is it developed malignant? Oh, sorry, I have one other question here. I'm 38 years old. Is it too late to freeze my eggs? No, it's not too late to freeze your eggs at 38 years of age. However, you have to keep certain things in mind. As I said before in the beginning, at 38 years, your egg pool may be poor. That is in terms of numbers. and then the quality may also be compromised because of age. But that doesn't mean, as long as you're seeing your periods monthly, there's a suggestion that perhaps you still have a significant pool of eggs to be evaluated. But the first thing you need to do is to approach a facility center to assess that quality. There are indirect ways that we can do. There are certain hormonal assays that we can carry out on you, that can be carried out on you, that will determine the quality of your eggs and to some extent what we expect when the process begins. Now, I need to add this that generally speaking, it is better at this point really to consider fertilizing or treating the eggs immediately at their removal rather than freezing them, because at your age there is a risk that, of course, we don't have the numbers and then the quality. So when you freeze them or use much later, you might just discover that at the point of fertilization later in life, they might not get us good quality embryos. So if you attempt to fertilize them now, if you have a partner, that's the best. So in other words, it is better to freeze your embryos now, that is, get the eggs out, get the donor or partner sperm to fertilize them and keep them. Thereafter, there and then immediately, you'll be able to assess the quality of embryos you have and thereafter decide. So it's not too late to freeze your eggs, but I think the sooner you approach the fertility center to do that, the better. How is cyst developed? How is cyst developed into malignancy? Well, clearly, of course, ovarians, I guess you're talking about ovarian cysts. Well, usually ovarian cysts are divided into different types. Usually the ones that are going to be malignant are malignant from the beginning. We have the non-malignant ones, which we call the benign. The benigns are benigns until the end of their lives. The malignant start as malignant. I'm not aware of a situation where a tumor or a cyst was benign and then transforms into malignant. No, that usually doesn't happen. But what we do have is that we have those ones we call borderline. But generally, malignant tumors or malignant ovarian cysts start up initially as malignant ovarian cysts, whereas the ones that are benign, non-malignant, usually start as non-malignant tumors. What plans do you have for installmental payments for IVF over a period of time? Now, in the spirit of this month, we have actually put up the waiting couple in our website. I think we put up the waiting couple provision, where we know that times are hard, especially in this part of the world. So we have a plan for couples who cannot afford to pay for IVF at once, a plan where we can do installmental payment until they're ready to. So we have that plan. So you may have to approach the hospital, specifically if you intend to use us, to give you details on that. What lifestyle modifications can help manage PCOS symptoms while also supporting overall health in cancer survivors? Well, generally, PCOS is a condition that we don't have a direct uh, knowledge of what exactly is the direct cause. But what we do, we know what happens in PCOS, we don't know what causes it. But essentially in PCOS, there's a hormone imbalance in the woman in favor of excess of more the masculine hormone. In other words, we call them androgens, than the feminine hormone, the estrogens. And that's the basic problem. But these problems start from the centers, the brain, that tend to regulate the menstrual cycle of the woman. So the basic problem is the fact that there's a hormonal imbalance in favor of androgens level. But there are factors that tend to encourage the occurrence of PCOS, or what we call associated factors. Weight is an issue that tends to be associated with weight gain in particular. So for those, though we have people who are lean PCOS patients, but generally speaking, a lot of PCOS patients have these difficulties dealing with weight gain. So one of the things that have been known, lifestyle changes that have been known to improve the condition, is weight loss. Generally, if you lose 10% of whatever current weight you have and continue to maintain that, it's likely that your PCOS and general lifestyle will improve. After all, generally speaking, weight or what you call excessive BMI, body mass index, generally is not good for any situation in life. So weight loss, and then of course these days there are so many things associated with that do not direct proof. I mentioned in the beginning of my talk that there are these chemicals or substances we call endocrine disruption chemicals, which have been which are known to predispose women to polycystic ovarian syndrome. So avoiding exposure to these things, I won't be able to talk in this is a huge topic on its own, but you might do well to go online, Google on what endocrine disruptors are, and look at those ones that are particularly associated or maybe linked with PCOS, and try as much as possible to avoid those ones, and perhaps the PCOS condition will improve. Does hydrosalpinx happen naturally, or does it happen if one has gone through surgery? Hydrosalpinx does not happen naturally. It happens in two possible situations. One, of course, as you rightly mentioned, yes, surgery. Post-surgery, if you have or develop adhesions, what we call adhesions, yes, hydrosalpinx can happen. The other way hydrosalpinx can happen is if there was an infection. Infection in this case, particularly what we call pelvic inflammatory diseases. Pelvic inflammatory diseases are the number one leading causes of pelvic adhesions apart from surgery. So these infections, when I talk about attempts at preventing contracting STIs, because ultimately in some women that eventually contract STIs, sexually transmitted infections, they end up with hydrosalpinx. So infections can cause hydrosalpinx. Surgery can also lead to adhesions that will cause hydrosalpinx. My adhesions are so severe that some doctors don't want to do hysteroscopy for me and remove them. The adhesion has made uterus narrow and thin, sir. Yes, I can understand. I mean, generally, following your evaluation, there are certain level of adhesions in the uterus that may not be safe to even attempt to clear out. Otherwise, the risk of surgery, the risk of damage to your uterus is high when you insist on solving them surgically. So the surgeons, your doctors should know what is safe to be carried on. Now, the fact that you have such significant adhesions does not necessarily mean that you can't have a child. Depending on your age, you may consider the option of surrogacy, especially where your doctors tell you that well the adhesions are so bad they can't even sort them out. So I think in this situation you can consider the option of surrogacy to have your babies. Now, what if it's one tube with hydrosalpinx? Will it affect the other tube? No, the other tube, hydrosalpinx in one tube may not affect the other tube. However, that can still affect your chances of conception to some extent, depending on the size of the hydrosalpinx. And because that tube that has hydrosalpinx or the fluid is still connected to the uterus, unless the blockage of that hydrosalpinx, the tube is also blocked very close to the uterus, the fluid has still the potential to flow into the uterus and may cause issues for you. Okay, the other question I see here is how long does it take to remove hydrosalpinx before embryo transfer? Well, depends on the approach to the hydrosalpinx. The best approach to removing hydrosalpinx is laparoscopically. That means using the little camera, what we call minimal access surgery. But if the facility you attend does not have such a capacity, then open surgery, maybe with a minimal opening in the womb, we call it mini laparotomy, can be used to approach this. Now, if you do it laparoscopically, within the same month, you can actually do your embryo transfer, or the next menstrual cycle, you can do your embryo transfer. If you do it open surgery, the place may still be, you may have to give yourself time to heal, because the cut and opening is made in the tummy, and that may not be appropriate for you to do embryo transfer immediately. So I would suggest that perhaps If you do an open surgery, you can just do a month or so or two before you consider the embryo transfer. But if you do laparoscopically, in fact, in the same month, actually, you did your hydrosalpinx, you can still do your embryo transfer. Now, someone asked about the challenges of managing PCOS with, following cancer. But now it depends on the type of cancer we're talking about. Generally, there are certain cancers that are considered hormone sensitive cancers, and those ones that are not hormone sensitive cancers. Now, again, I don't know what kind of cancer you mean, but I want to assume that you mean reproductive tract cancers, maybe ovarian cancers, and all of that. Now, where this, I want to believe that following cancer survival, certain treatment protocols might have been instituted on the person, which may include surgery, which may include radiotherapy, which may include chemotherapy. Now, all of these things, depending on, as I said, the type of cancer, may or may not have affected the person's ovaries, where the PCOS condition is. If the cancer treatment does not affect the ovaries and there is still PCOS following cancer, of course, it probably lifestyle modifications will be, the approach will be lifestyle modification. But depending on the type of cancer, as I said, if the cancer is not hormone sensitive, there are certain hormonal treatments that can still be instituted, like the combined pills that will address and suppress the ovarian function. But if the cancer was a hormone sensitive cancer, of course, in that situation, the only way out is to actually also use medications directly aimed at suppressing ovarian function. In this case, we talk about what we call the GnRH analogs, which come in the form of injections that the patient can take monthly or 3 monthly. But again, the best person to advise in this case is your managing team. I believe, depending on the cancer you were talking about, your managing team will probably have included a gynecologist and maybe an oncologist. This team should be able to advise you on the best way forward considering your polycystic ovarian syndrome. How long does it take to remove? Okay, those are any other questions? Okay. Um, let's see. Sorry, let me go through how long is it. This is the last question. Okay, I see another question here that says, what supplements can I take for the health of my eggs before freezing? First and foremost, we need to understand that, see, whatever the first most important factor you consider is your age. That's very important. Now, irrespective of the age, there are certain things that have been shown to improve egg quality or health. But generally, these substances also improve general cellular health. And in this group, we have what we call antioxidants. Specifically for egg health, there is a supplement that's called inositol. It comes in different formulations in the market. There are different formulations of that. your doctor, your gynecologist who can guide you on that. In Wildlife Hospital, we have particular brands that we use. Is it true? Is it true folic acid increases fibroid growth? I do not. I'm not aware of this information in medical literature, but well, from what I know about fibroids, there's no direct association between folic acid and growth of uterine fibroids. Is there anything or any drug one can take to increase chances of having twins? Yes, of course, there are medications. Now, when we talk about twinning, one thing we have to know is that there is what you call, there are people that have the genetic predisposition to having twins. In other words, people who have twinings in their family. So, for these people, they probably don't need any medication to increase their chances of twinning. Now, for people who don't have history or chances of twinning in their family, of course, for them, we need to keep in mind that twinning occurs when a woman releases more than one egg in one menstrual cycle. In other words, when at the point of ovulation, you have more than one egg released, of course, you have the chance of having twins or triplets or quadruplets, as the case may be. Of course, we do know that sperm cells are usually released in millions, and as many as there are eggs available for fertilization, the sperm cells available would fertilize. So there are medications that people give to, but generally, I want to advise that you should contact a specialist who will advise you on specific medications that are appropriate for you. Don't do over-the-counter medications, because sometimes we have people who have pre-existing medical conditions that may preclude the use of some of these medications. So I will advise that before you do that, you approach your gynecologist that will guide you into what is appropriate for you. I'm 36 years with bulky uterus adenomyosis. Can I take the medication before I freeze my eggs? Now, for adenomyosis, yes, you can take, but of course, adenomyosis do not directly affect your eggs in any way. Adenomyosis only affect your uterus, the womb. So that may not have any bearing on the quality or quantity of your egg. So you don't need to address the adenomyosis before you consider freezing your eggs. I think you can just go straight away if it is if it is endometriosis, on the other hand, that may affect your eggs, and you need your doctor to evaluate you on this. Can a woman have endometriosis and adenomyosis same time? Yes. Yes, it's possible to have endometriosis and adenomyosis. Actually, endometriosis is more probably an extension of adenomyosis. In other words, endometriosis is where a situation where the interior or lining of the womb cavity is present in other places outside of the womb itself. Adenomyosis is where the lining is present within the womb muscles beyond the cavity. So it's possible to have both, yes, the same womb. Yes. But of course, again, the diagnosis will be subject to proper evaluation by your doctors and gynecologists. Can a very large ovarian mass cause uterus removal? No, except where the mass is attached adherently to the womb, to the uterus, in the manner that it will be dangerous to separate them at the point of removal. Otherwise, the ovarian mass can be separated and removed without necessarily affecting the womb. But where the ovarian mass is adherent or morbidly or tightly attached, especially where the surface area is large, and there's a consideration that perhaps an attempt to separate them will lead to excessive bleeding, or where there's a suspicion that the mass may be cancerous and therefore removing it, separating it from the womb may not be feasible or advisable, then of course, in that situation, the womb may go along with the ovarian mass. Otherwise, the ovarian mass removal does not necessarily affect the uterus. So basically, some of these, we see quite a number of questions coming in, and we may not really have enough time to address all of them. But what we're going to do, the hospital, we're going to look at some of these questions answer them at a different time and post them in our social media handles in terms of articles or some videos maybe on the YouTube, depending on how significant we see the questions. But we do hope that because we've spent more than 1 hour, we had already, at the beginning, we had said that we're going to spend just an hour, but now we've spent more than an hour. We have to apologize that we actually didn't start exactly 3 on the dot for technical reasons. But we see that as it is, with the number of questions that we people have, we may not be able to address all of them in one sitting. But as I said, at the hospital, we take responsibility to make sure that beyond this forum, we try as much as possible to address some of these questions that we have not been able to address here and post some of them via our social media handles as well as YouTube, with the hope that in the end, little attempt at creating awareness uh, is achieved. Beyond the month of June, the Wildlife Hospital is still here for you guys. We have said before, as much as possible, we want to give back to the society as much as we can in our own little way. Of course, we may not be able to help everyone, but at least those who we can help in our capacity, we will try and do that and hope that we are able to help you to achieve your fertility dream. Ultimately, we say in Wildlife Hospital, your our goal is you having your child in the end. So we thank you very much for your presence, for being with us, and we hope to see you soon other times by the grace of God.